genetics. So, and the genetics is ruling out pathology as a cause of injury, like we talked about. Okay? All right. Why are we doing all this? Seems obvious. Why are we doing this? First, we have to decompress the skull. I know we're not going to have much to talk about. And we have to protect the patient from additional injury. Now we're at our favorite, nursing implications. History. Get the information from the first responders and caregivers separately, right? Can't have everybody in the room at the same time, which is difficult because everyone's in the room at the same time. So you have to kind of separate it out. Best practice is for the first responders to give report to more than one person at the same time. So we see that all the time. EMS comes in, gives the report. We all hear it the same way. You know, we all hear the same information, which avoids hearsay. Get a legible copy of the pre-hospital report. When taking the history from the caregiver, now this is interesting, use active listening and facilitated monologue. And get details pre and post event, and you don't ask leading questions like, I understand you found this patient in the tub, right? Can you tell me a little bit about what happened? Right? Open-ended questions. We're really terrible at this because we love to like insert the information so we can move on. So listening first. Also, when you ask a question, wait for the answer before you help them with it, right? It seems funny, this is information that you can use for all interviewing skills, okay? Like ask, listen, and then decide, okay? Detailed of all physical findings, including patient and family. So this is where you literally discuss all that you know. Be objective and specific when you're describing who you're referring to. You avoid he, they, that kind of thing. She said. Who's the she? The parent, the child. Who are you talking about? The caregiver. Be specific. If you have a name, it's even better. Okay? Because sometimes you say mom, it's not really mom, it's aunt. Right? Right? So be really specific if you can. Photography. What do you guys think our hospital policy is on photography? Can you take out your cell phone and take a picture? No. Is it really common that people try that trick?
Yes.
Yeah. You don't do that. Because here's the thing. A, if your phone gets stolen, right, it's completely not protected. People definitely get into like physicians will want to send pictures from their phone to another physician's phone, right? It's not identified, so it's just not the right answer. You're absolutely allowed to say that's against our hospital policy. Yeah.
Also, Stacey, family history is so important, especially in an emergency room setting, where English is not the primary language, big time. Very important to get your translator because a lot is missed, and also oftentimes culturally people would nod yes when you ask them a question, even though they don't understand the question.
No, that's perfect. Interpretive services is not actually a nice to, it's a have to. And especially in these situations where information is so important. Information is always so important, but you don't want to be misinterpreting their answer, right? Excellent, thanks for bringing that up. So, this is an interesting thing. Check your own perception or biases against the facts at hand. Don't dismiss any injury as isolated because the child looks like they came from a nice family, where it looks all intact. Another high risk are twins, right? Families with twins, just because it's twice the challenge, right? So, you know, we've had wonderful families where the mom and dad are intact, and you do have momentarily loss of control. That doesn't mean they're a lifetime criminal. It means they might need support or something bad has happened. So, this is really common. This happens actually in pediatrician's office. They'll call up and lead by, it's really a nice family, but, ... right? Also, you might relate to the family, or you might think to yourself, oh my gosh, they look exactly like me. I would never do that, right? Okay. So, this patient's identified injuries were this extra-axial hemorrhage, subdural and epidural hematoma, cerebral edema, herniation requiring immediate surgical decompression. Child, like you guys identified, had retinal hemorrhage, liver lac, left and right ulnar and radial periosteal bone formation, blah, blah, blah. This kid had fractures, Okay, skeletal survey showed fractures. Numerous skin findings, abrasions on the chest, pattern abrasions, lesions to the chest and upper arms. This kid did have sentinel injury, bruising behind the ear. What's interesting is they may come in, like this patient I was discussing that may have taken something. The bruise behind the ear initially in the ED was so faint, you probably wouldn't have seen it. That was even before it gets reddened. It was really light. Now as the time has progressed, it's not light at all. It's purple, dark, and very noticeable. Okay? So that's how you can go back down a path. That kid's injuries were found immediately on CT, but that's fine. Okay, CCP determination that the injuries were consistent with violent physical assault. Okay, so the probability of survival. This particular patient had a 13.7% probability of survival due to the GCS, the injury severity score, and age. Kid had polytrauma. The most significant injury, of course, is the TBI. The liver lac did resolve, had to have blood product transfusion. They have received intensive rehabilitation from PT, OT, speech, 6 days per week. The child has left hemiparesis, is at high fall risk, wears a helmet at all times, and has really poor safety awareness. The kid's gait is off and requires close supervision and must have hand contact with standing or ambulation. Significant sequelae. They were discharged to foster care, to a relative placement. After a lengthy hospital stay in intensive inpatient rehab, they are able to ambulate household distance with standby assistance, can go up and down 4 steps with assistance. They're able to feed themselves with minimal assistance, and their cognitive disability is they have problems with learning, short-term memory, concept formation, and retention. They tend to echo each other, echo others, they just say what they hear. And minimal content in the communication. They're words, but they don't really mean anything. So, the lessons learned. Young children are at high risk for non-accidental trauma, like we've talked about. Detailed history of event from parent or caregiver as soon as possible is the priority. This is so the stories don't change or that people don't get advice from people. Thorough documentation of every detail is of great importance. Non-accidental trauma has a high incidence of mortality and morbidity. Isolated injuries may not be isolated, so this is where you seek consults. You seek optho and different things, ortho on skeletal. Recognize your own personal bias, be objective and focused on the facts. And according to Dr. Crawford Jakubiak, be the intervention that allows the child to come back for their next check. These are just references. I'd like to open to questions and comments about non-accidental trauma or anything. Yes?
Good talk, Stacey. I'm just getting back to the photography. Do you guys have a department here and any kind of policy guiding that?
We do. We do. And there's very specific ways of how to use it, and it's a particular camera. And there's certainly a place for photography. It's just not your personal cell. It's kind of what I was getting at. This gets to be a challenge too when families bring in phones, just as a different conversation. You know, they bring in their own phone and they say, I'm going to be, filming the whole procedure. They're not actually allowed to film your image. So they actually can't take video of you starting that IV or missing that IV or whatever, because you haven't given permission for that. Okay? So that's just fine. And we do have policies in there. Okay.
What do you do with the families during your resuscitation and all that part?
Very good question. We absolutely believe in patient and family-centered care and having the patient in there. In our regular, sorry to use that word, in our regular resuscitation, we absolutely welcome and want families in there. Even in a non-accidental trauma, you could have families in there. They always have to have an escort, 100% of the time. Whether it's social service or another RN, security's awkward, so I wouldn't have them in there. You know what I mean? They're not medical people, so they can't explain what's going on. But they have to be escorted. If the family is, what we were saying, that hostile or detached, that wouldn't be appropriate. It's the attending's final call if they don't want someone in there. Okay, but we absolutely want them in there. Okay, so it's a good question, and we really are encouraging it. It's a learning curve, and it's a culture change in this institution, especially in big resuscitations. Many, I don't want to say older, but more senior physicians may not be comfortable with it, so we need to educate them. Yeah.
One question. We're talking about physical abuse, but what about the non-physical or verbal abuse? Do we have to be suspicious of that?
Absolutely.
And, you know, moving to physical abuse after?
It's a very good question. We see it sometimes where the interaction is so uncomfortable that they're fighting or calling them names or are angry at the child for being sick, angry that they have to be there. That is absolutely suspicious, and you absolutely report that. Because verbal, physical, even nonverbal, you know, where they're indifferent to their child. We've had where the mom comes in with a baby. We've had like special needs babies where the mom comes in and puts the baby on the gurney. Just literally lays them there and stands back. That's not the standard way, right? So that's a level of suspicion. Plus that kid has disabilities, so that's another tick. These are all flags. So a child indifferent, abusive verbally, they swear at the kid, that kind of thing. All right? Really good question. It's everything. Sometimes silence is what's the abuse. Yes?
So if you suspected sexual assault, would that be under intervention for the primary nurse, or would that be another consult for a specialty?
We actually are the receiving center for sexual abuse and molest for patients under 14. We see every age, but we would refer over 14 to an adult facility because that's a different forensic kind of an exam. So we absolutely notify our team, and it's absolutely our responsibility. Absolutely. Good question. You know, this is kind of a bummer topic, but I have much better things. Anyhow, but it's certainly about saving lives and intervening. And believe it or not, it'll make you feel good if you recognize something and can intervene. You've made a huge impact. And what we say all the time in the ED, every day you want to have an impact in some way, right? And this might be your impact of the day. And sometimes it isn't the giant thing that we did this huge fluid resuscitation and push the blood and da. Sometimes it's just recognition and reporting and documentation and clear documentation. Any others?
Well, I just have to address that additional importance of documentation. In the ER, I had a foster mom who was right there at triage, hitting the kid. And also because he had dark skin, it was very difficult to see any physical, you know, the different colors of abuse. But that's why you have to kind of document all the other way how he's presenting. He's fearful, things like that. So it can happen across the spectrum. Just to be aware of that.
Excellent. The other thing too is, so you're taking care of this patient and you see that they're hurting the SID that came along. What's your responsibility there, right? To intervene. Even though the patient they brought in, you're dealing with, because they brought that one in for illness perhaps. But then you're noticing some weird dynamics going on with the other patient. I mean, the other child. Anything else? Okay. And we have a new policy actually that will be going out next week. It'll be in the ED-PNPs on the ambulance icon, and it's an interdisciplinary policy on non-accidental trauma. And it's really good. Okay, thank you very much.
Stacey, I just want to remind everyone we have an evaluation at the end. The evaluation. These are all fine. Just to make sure you fill that out, it's really helpful for me to know what topics you're interested in for future seminars. So we're kind of ahead of schedule. Why don't you go ahead and take about 20 minutes. Hopefully Dr. Bell will be a little bit early. There's some snacks